starting last June. So I see patients here as well as in the outpatient building on the Broadway campus. And I'm happy to be here. Today I'm going to be talking about weight management and autism spectrum disorders. So today we're going to understand overweight and obesity classification, understand the basic trends in overweight and obesity prevalence here in the United States, and talk about the risks of overweight and obesity, and understand factors that attribute to overweight and obesity in children with autism spectrum disorders, and understand the process for improving nutritional status of children who are overweight and have autism spectrum disorders. So typically when we take our child, those of us who have children, when we take our child to their annual physician's well-child visit, and also for any other doctor's appointment, they'll measure our child and weigh our child. And what they will do is they will plot on a growth curve to see where the child falls. So typically when I take my kids, the physician or the nurse will say, oh, your child is at the 50th percentile for weight and the 40th percentile for height. These are, from a nutritionist perspective, sort of really, really important measures that kind of determine and assess, help us measure the effectiveness of the nutrition status of the child. Most importantly, where a child plots, it's not necessarily important what percentile they're at, but more importantly that they are tracking on that same growth curve over time, so that a child isn't starting out at the 50th percentile for weight and then all of a sudden at their next annual visit jumping up to the 80th percentile or something like that. So speaking about expected growth, we do expect our children to grow in a consistent pattern, and that would be sort of following along on similar growth curves, so staying on that expected growth path. What is less common at a physician's, a child's physician's doctor's appointment is that it's not as common to hear about what the child's body mass index percentile is. They do, however, take them and note those measures. So why this is important is because we're really assessing a child's proportionality. How proportionate are they, is their weight per height? And we do this by checking the body mass index percentile. So for adults, most of us have heard of the body mass index. However, for children, we calculate a body mass index and then determine what their percentile is, where they fall in the percentile charts. So based on the CDC classifications, once we determine a child's body mass index percentile, we can sort of put them in one of these categories to help determine if they're underweight. That would be kids that fall below the 5th percentile. If they're at a healthy weight, it's somewhere between the 5th and 85th percentile. Now that's a really big range. And the reason for that is because kids grow at different times and at different rates. So there's a big range which we consider healthy. Also because different children have different body shapes. Once a child is at or above the 85th percentile to the 95th percentile for body mass index, then they're classified as overweight. And anything at or above the 95th percentile is classified as obese. So I just want to point out that here at Kennedy, the nutrition department actually uses the 10th percentile as sort of a cutoff point for underweight. We just like to be a little more conservative with our population that we're working with here. But these are the sort of the quote-unquote official Centers for Disease Control classification cutoff points. So these are the body mass index percentile charts. So just as we talked before, a child will get a measure to determine where they fall percentile-wise according to their weight per height ratio. So how do we interpret these results? So this is a typical growth curve for a boy. And so falling down here, let's see, down here you can see, so this green curve, the whole green segment is the area between the 5th and the 85th percentiles. So that's sort of the healthy range. So a boy, a 10-year-old boy who was falling down here with a body mass index of 13, his percentile is less than the 5th percentile. So he would be considered underweight. A 10-year-old boy with a body mass index of 23 would be above the 95th percentile. So they would be classified as obese. Okay. So we've all heard many reports in the news about the prevalence of obesity climbing, and especially in the last few decades. The prevalence of childhood obesity has really become more prevalent and of great concern. So based on a study that was published in 1998, we can see this is indicating what percentage of 6 to 11-year-olds are classified as overweight. Now keep in mind, this is the classification of overweight, it will include the folks who are considered obese in that total percentage, okay? So between 1963 and 1970, 4% of children were considered overweight. And if you compare that to 1999, 12%. So even in those 3 decades, those 30 years, the rate tripled. However, when you're thinking 12%, you might think, that's not so terrible. But the point is that the rate did triple over that time. And those trends have continued in the last years as well. So more recent data taken from the NHANES, which is a large national survey of nutrition and health information, indicates that 32% of 2 to 19-year-olds are considered overweight. So if we're going back to 1999, we had 12%, okay? And so that prevalence has more than doubled, almost tripled, and even 17% are considered obese. So what do the trends look like for children with autism spectrum disorders? There have been several studies, and interestingly, none of the studies are exactly giving the same results. So there's a little bit of discrepancy between some of the studies. So in a study published in 2010 using the National Survey of Children's Health Information, they indicated that the prevalence was 30.4 of the kids were obese. And those are children with autism spectrum disorders. And if we look back, the national average was 17% for obese children. So quite a significant difference. A more recent study indicated that 39% were overweight and obese, with 21, almost 22% being obese. So the 39%, that total amount, is not so different than what we just saw indicated as the national average. However, a higher percentage, a significantly higher percentage of those in that category are classified as obese. And then the last study in 2015 found that a little more than 51% of children with autism spectrum disorders were overweight and obese. In that particular study, the most sort of notable difference was that there were differences present in as early as 2 to 5 years of age. And when comparing children of the national sample. So that was a noticeable difference. All right, so what are some of the factors that attribute to overweight and obesity with children with autism spectrum disorders? I've got them listed here, but anyone have any thoughts? What might be some of the contributing factors? So food selectivity, absolutely. Yep. Anything else?
I don't see that there. Is there any evidence for like any kind of like genetic components that could impact it?
So that's a really good question. Is it okay if I come back to that in a little bit? But that's actually a fantastic question. Yeah. So we'll go over all of these in more detail. And so starting with food selectivity, in a study published in 2014, it indicated that children with food selectivity, children with autism spectrum disorder who had food selectivity, often those foods were very energy dense foods and often kind of fell within the same food group. So if an individual eats 7 different foods, they might be cheese crackers, pretzels, chips, all kind of falling in one particular food group. Additionally, in 2012, a group of researchers found that children with autism spectrum disorders don't consume adequate fruits and vegetables. And other information that we know is that eating less fruits and vegetables is associated with developing overweight. And children with autism spectrum disorders are more often described as picky eaters and have aversions to specific textures or colors or smells, temperatures, or maybe brand names of food. And one study I saw indicated that 50 to 90% of this population have some sort of quote-unquote food problem, whether it's food selectivity or aversions or something of that nature. But 50 to 90% is tremendously significant. All right, so there's a lot more information and publications about the lack of exercise in this population. So motor skill difficulties can really attribute to children with autism spectrum disorders not getting enough exercise. So that might be sort of the unevenness of acquiring developmental milestones, maybe low muscle tone, or postural instability. And that may affect endurance, balance, motor planning, and may result in exclusion from activity or reduced motivation to participate. If it's hard to participate, you might not want to. That might not be something that you're going to seek out. And certainly social skill and communicative difficulties can attribute to children not wanting to participate in certain physical activities. So just a couple of interesting notes. Children with special needs may have fewer opportunities for physical activity because they may need some sort of adaptive help or equipment at times. Parents report that children with autism spectrum disorders participate in fewer types of activities. And physical activity declines with age in children with autism spectrum disorders. So they might be more active when they're 4 years old, but when they're 14, much less so. And parents may not feel comfortable allowing their child to be physically active on their own. They might feel that they need additional supervision in some situations. All right, so medications. I have a few listed here, but there certainly are many medications which this population uses that are associated with sort of undesirable weight gain. And even 30 to 60% of children with autism spectrum disorders use one or more psychotropic medications, many of which are associated with weight gain. And I just want to note that what I'm about to say is sort of my sort of anecdotal findings over time. I have not been able to find any information in the literature that sort of supports this thought. But what I find a lot is that when I'm working with children with autism spectrum disorders, I almost feel like the population often has a hard time sort of processing the signals of feeling full. And I don't know if that's, maybe there's, maybe it's just a behavioral component. Maybe a child is just used to seeking out food and it's pleasurable. Or if it's an actual inability to feel full. Because often parents will report that their children are constantly seeking food, stealing food, hoarding food, finding food. So again, I have not seen anything in the literature, but my anecdotal experience is that I wonder if there is some sort of connection there. Okay, and parenting style. So parents might try to compensate for their child for their medical diagnosis by allowing them kind of their preferred foods, even though they know those preferred foods might not be the healthiest choices. And oftentimes that might establish habits at an early age. And then also it's difficult to know how and when to set limits for your child. Okay, and then finally just our lifestyle in the United States. We are a much more sedentary society than we were 30 years ago. We have a lot more labor-saving devices. We've got food advertisements and media messages that kind of make it desirable to seek out certain types of foods. And a lot of those foods might not be the most nutrient-dense and healthy foods. We have an on-the-go, fast-paced lifestyle. Many times, it might not be convenient to make a homemade dinner, and convenience or fast food might be a much easier option for families. I saved the first little dots, the first little bullets for last. That's a little bit more about screen media. So certainly we have so many more options for screen media between video games, iPads, phones, television. There are certainly a lot of choices. And children with autism spectrum disorders spend more time on screen media than their typically developing peers. And children with autism spectrum disorders start using screen media at a younger age as well. So all of these factors kind of create a picture of kind of indicating why, the prevalence of overweight and obesity is so high. Did you have a question, Jenny?
Yeah, I was just going to say, I totally agree with everything, but in our triage process, one of the things we have to focus on is nutrition and appetite. It's part of the triage questions. And one thing that is kind of frequently reported by the parents is that the child can't sit still at the table for very long. They're so hyperactive, which that's a very common denominator with the kids that we see, especially the younger kids, that they might be able to sit and eat for a couple of minutes at the table with the parent, and then they can't sit anymore. So they get them down, and then they're grazing for
Often.
like grazing, meaning they're just picking up a preferred food. So
Sure.
I find that parents don't even maybe realize that nutrition is really poor overall when they paint that picture on a day-to-day basis.
Sure. If a child is sort of grazing throughout, 2 or 3 hours for a meal, it's harder to know what they're actually eating during that time.
Right.
Yeah.
And the quantity.
And the quantity, yes.
They lose track of that.
Absolutely. And to go back to your question about genetics, so I don't know a whole lot. However, there certainly are certain diagnoses that are, or certain genetic markers that automatically place someone at higher risk of obesity. And I believe, I am pretty sure that, well, let me, do you know?
So if you have a diagnosis like Krieger, really,
Certainly,
put you
yes.
or like a backward Biederman or something, and they have a tendency to be overweight.
Correct.
So you might have early feeding issues as a baby, but then later on
Right.
they tend to be obese. So the kids, you hear the history of the parents that actually get a lock and put a lock on the refrigerator. So that's very classic. You get with kids with Krieger and so on. So it's always important to screen.
So actually, I was trying to remember, I feel like I've read this, and you might not know the answer, or someone else might know the answer too, that there was I thought I read that there was a genetic marker that was associated with autism spectrum disorders, but individuals with that marker also were at a much greater risk of overweight.
So Angelman's Krieger, they all
Sure.
the same with the
Yeah.
15p chromosome. So there are certain chromosomes that are heightened with autism and obesity.
Yeah.
Those are the main ones that I know. And then there's some of them also have sleep disturbance, like less
Mhm.
pregnancy, then if your sleep is disturbed, you're up more and then you're eating more. So
Yes.
that is like secondarily causes obesity.
Yes.
It might not directly cause
Yes.
obesity.
Yeah.
So it could be because you're affecting some other part of the cycle.
Mm-hmm.
And if your circadian rhythm is not right, then you might start overeating.
Yep.
Because you're up more.
Absolutely. Does that help with your question a tiny bit?
Yeah, I just think it looks like a lot of these things were sort of more like lifestyle or
Yep.
environmental, and I think there's also some kind of
Mhm.
biological component
Absolutely.
or a genetic component as well
Yeah.
to some of these things.
Yeah, I don't know. I don't think all of those questions are answered yet. Yeah. Yeah. Okay, so why are we concerned with overweight and obesity? So the first bullet I have up here is that individuals, children certainly, are much more likely to be bullied or teased if they're overweight or obese. Children, overweight or obese children are much likely to become overweight or obese adults. And that is a risk factor for many chronic diseases, so including heart disease, type 2 diabetes, high blood pressure, high cholesterol, stroke, sleep disorders such as obstructive sleep apnea, osteoarthritis. So oftentimes people who are overweight might develop pain in the lower extremities, in the ankles, the knees, or the hips. Sometimes early onset of puberty, asthma. Some types of cancer. I have cancer written here. I should be more specific and just say some types of cancer. And then again, individuals who are overweight or obese suffer from negative societal bias. And yeah. Okay, so in 2007, the American Academy of Pediatrics released a pretty significant publication providing guidelines for preventing and treating overweight and obesity for children. It should be noted that this publication did not have a component focused on any type of developmental disabilities. However, it provides good insight and guidelines for developing programs for treating individuals with obesity, children with obesity. And certainly it's really important to think about any type of program. How are you going to adapt that program, or how are you going to adapt your treatment for the population that you're working with? So how are you going to enhance accessibility, ensure that any programs you have are inclusive, and how can you engage? How can you engage your group? Okay, so we've sort of got this really nice diagram here, and we've got three main layers, three main tiers. The first is child and family characteristics that we can sort of think about, the factors that need to be thought about when we're trying to address and treat obesity in an individual. So certain patterns like screen use, as we already mentioned, medication use, mealtime stress, if there's a lot of tension around trying to get a child to eat a certain food or not eat a certain food, sleep problems, and then family factors such as is the family physically active? Does the family sit down and eat a meal together? All of these things are ways that we can kind of start to think about how we can sort of pinpoint and direct our interventions that we're gonna probably in most cases will end up being sort of a personalized approach, because no family is the same. Also, school can help. So understanding the school food environment, and is the school using food as a reward for certain behaviors? I see that a lot. That's a big challenge. Sometimes a school might say, the only thing that motivates my kid or motivates this child is food. And that can be a huge challenge. And then the final circle, the final bubble here is at the community level. What can we do at the community level? Having policies to ensure inclusion and ensure that there are physical activity programs in the community that are appropriate for children with autism spectrum disorders. and that there are appropriately trained personnel or coaches that are involved in these settings as well. Okay. So I think I covered probably most of these, but some interventions a family can implement is that, first and foremost, if you're trying to change the eating habits of your child, it's always best that you're going to model that behavior. Setting a good example. So if you want your child to try Brussels sprouts, it's probably a good idea that you eat Brussels sprouts too. Good sort of family dynamics, such as serving meals and snacks at regular times, trying not to be a short order cook, which is a huge, huge challenge. Let's see. And then if a family is in a situation and they feel that they need additional resources to manage their situation, that's okay. There are additional resources out there. Okay. So the school environment can ensure that there are inclusive physical activity programs that are meaningful to maximize participation by children with autism spectrum disorders. In lesson planning, it might be necessary to ensure that nutrition concepts are covered in a way that aren't abstract and can be applied in sort of a real world context. And then community interventions. So some really good programs out there include adaptive sports programs, things like community gardens. They can really help kids understand where food comes from. And also, if you're involved in if a child is involved in a community garden, they are much more likely to try the food that they're helping to grow. All right, so I find that it is really, really important to identify at an early age kids that are at risk for becoming overweight or obese. So that might include really following those growth parameters that we talked about at the beginning, and any kind of sudden shifts in those growth parameters, in their height or their weight, those should be noted. And it's always easier to work with a child or family before something becomes a significant problem. So early kind of intervention and detection is really best. And then a family might be, certain parents might be able to say, okay, I think we really need to change some habits here. And they might be able to feel very comfortable doing that on their own. However, please know that there are a lot of other resources available to them if they need additional help. So one is the nutritionist. Here at Kennedy, we also have a feeding program that works with children who do have very selective eating habits. And then in some situations, a behavior therapist might be appropriate to include. So I kind of tag team with behavior therapists all the time. So for example, I might have a child that comes in and the parent tells me that their child is really sneaking foods or having a lot of tantrums about foods if they're not getting the foods they want. And if they're working with a behavior therapist already, that's a good time to sort of communicate with them and to develop a plan together and say, you know, can we put some mechanism in place so that the kind of negative behavior around food is not there, because that will make everything a lot more smooth around mealtime. And then again, as I mentioned, involving the entire family. So we have lots of research that shows that making behavior change is most successful when the entire family implements those changes. Okay, so I already mentioned body mass index percentile screening. And I previously mentioned that significant publication from 2007 that addressed how to treat children, how to sort of manage children who are overweight and obese. And that publication identified several key behaviors and said that, you know, if we kind of pinpoint and have good habits in these specific behaviors, then we will affect the obesity rate in our countries and on the individual level as well. So a lot of those are super common sense kind of things. So they include have a diet rich in fruits and vegetables, limit consumption of sugar-sweetened beverages, keeping in mind that sugar-sweetened beverages includes things like sports drinks, sodas, but also juices. Limiting screen time to 2 hours a day, promoting moderate to vigorous physical activity, and promoting a diet rich in low-fat dairy, whole grains, and lean protein, and encouraging consumption of age-appropriate food portion sizes, and having a diet that's consistent with consistent meals and snacks, including breakfast. All right, so who has seen this diagram? This is called the healthy plate. This is what we teach now. So when I was in grade school, I learned about the food pyramid. People remember that? Okay, so and the food pyramid wasn't particularly user-friendly. However, the food plate that we're looking at here seems like a very kind of basic tool. However, I think it's really useful. When I'm working with families, the first thing I'm telling them is, you know, look at that line down the middle of your plate. That tells us that half of what we're eating, half of everything on the left side of that plate should be fruits and vegetables. So that's like a key. Half of what we're eating should be fruits and vegetables. Okay? All right, so it's important to remember that within each of these food groups, we want to aim for variety. So as much as possible, variety within each of our food groups that we're eating. And moderation, so that goes back to appropriate food portion sizes. And just keeping in mind that as children age, their nutrition needs will change as well. So, okay, so I put this case study in because I think this gives us a good sort of segue into any questions you all may have also. Okay, so this guy, EH, is a 12-year-old, 2-month-old male with a history of ASD, PDD, sleep disturbance, and anxiety disorder. He is a very selective eater. He rarely eats fruits or vegetables. He drinks juice and soda, no water. And he spends his free time on his tablet. And the family relies on fast foods several times a week and other convenience foods. His body mass index is at the 99th percentile for age and gender. So first of all, just looking at his body mass index percentile, how would we classify him? Can you guys remember the breakdown? Yes, he would be classified as obese. And do you think what are sort of some of his risk factors that you're kind of identifying? So maybe some behaviors that are are sort of putting him at risk for obesity. Did that make sense? So no water, okay. Yeah.
Soda and juice.
Okay, good. So he's drinking sweetened beverages. Okay.
Sleeping well.
He's not sleeping well. Excellent.
Anxiety.
Yeah. Right. What about the? Say it again. No exercise. And what about the tablet? So a lot of screen time also. So if we're thinking about just behavioral changes and behavioral interventions, typically I like to think of 2 or 3 behaviors at once. Any more than that becomes a little bit overwhelming for families typically. So my approach is that I do not tell a family what to do. When we're talking about behavior change, it's typically not the most effective approach, because I can tell people what to do all day long. However, if they're not interested, or if they don't think that's a change that's going to work in their household, then it's really not going to happen. So I try to have the families identify what they think is most important to change first. And then you have a little bit more motivation and interest in that regard. So I can tell you that this particular family had been to, before they came to see me, had been to a nutritionist prior, so a couple years ago. And the mom told me that they went for one visit and just didn't really like what the nutritionist had to say. So I knew right away that I had to sort of approach this carefully, because if I turn mom off, then I'm really not going to end up helping the child. So I did a little bit of motivational interviewing with this mom, and asked her questions like, well, why do you think, because the child was referred by the sleep specialist. So I asked, well, why do you think the sleep specialist referred you to me? So that opened up a conversation, and it was a positive interaction and a nice way to approach things. And she was able to kind of agree upon and identify a couple of behaviors that she really wanted to, that she thought were doable in their lifestyle. So one was that, let's see, so she was going to have her son eat 3 bites of vegetable at dinner time. And the second goal was that she was going to have him drink water throughout the day, but that he was allowed 1 soda at dinner. Okay? And I don't think she had an exercise goal, because she thought that would be too difficult at the time. But those were her goals. And so that's where we started. Yeah. All right. Yes?
Would you have suggested to her, though, to change the intake of the soda from night to maybe the afternoon, given all that sugar?
Yeah.
Probably,
So,
you know.
so ideally, I'd rather him not have any soda.
Well, right,
Yeah.
I know that.
However, yeah.
But with her having it as something she still wanted to implement in his diet, like she still wanted it in his diet, would you have then suggested
So
to
this
change it?
particular mom really felt like dinner,
Mhm.
like that
That's
the soda had to be
Okay.
there.
Okay.
Exactly.
Yeah.
Yeah.
Okay. No, I was just curious
Uh-huh.
as to.
Yeah, that's a good question.
Yeah.
Yeah. Mm-hmm. Any other questions? Yes.
My child is, when she's eating
Yeah.
And when she's eating lunch, she's thinking about dinner.
Yeah.
And she says it
Mhm.
while she's eating, what are we gonna have for lunch?
Mhm.
What are we gonna have for dinner?
Mhm.
And in school, they feed her all day long.
Mhm.
Fruits, though.
That's
but
good.
they do give her stuff all day long when she comes home with food. So I'm trying to, because she wants to eat all day.
Right.
Even when she's going to bed, am I gonna have a snack? Are you gonna wake me up for a snack?
Aha. Okay. So depending, so I don't know your daughter, so I'm just making a suggestion, and this may or may not work for her.
She's hoarding food.
Okay.
When I go down to check on her,
Yes.
she got a banana under
Her bed.
bed.
Mhm.
She got bottles of water. She drinks water all the time.
Good.
Just stuff, snacks.
Okay.
She's taking out the kitchen, and sometimes she eat them, and sometimes she's not.
Uh-huh.
Yeah,
Yeah. But she has,
a foster child too.
yeah, and so she has like a genuine concern that she might not eat again.
Eat again.
Yeah. And maybe, how long has she been with you?
Since September.
So, and maybe where she was before, maybe that was an issue.
Right.
So we want to be sensitive to her prior experience or trauma. So what has worked for a couple of families I can think of is sort of making a schedule, a chart, so that she has access and can refer to it. So whether it's, I'm not sure if she tells time or not. Okay, so then you may think of making sort of a schedule board for the afternoon. And so that if she comes home at 4 o'clock, when she comes home at 4 o'clock, the first thing she's going to do is playtime. So maybe there would be sort of a pictorial diagram that would indicate play with toys or something. And then depending on the rest of your routine in the evening, you might kind of indicate what is happening sort of in the row, or in a row. And every time she asks, now you can take her, kind of walk her over to this board and say, okay, right now is playtime. It'll be dinner time at 5 o'clock after playtime, and just gently sort of get her to use that tool. It would be a process. She's not gonna learn that overnight, but slowly she has the ability to do that. And it sounds like you're already addressing lots of questions, so it wouldn't be like you were addressing a new question.
Right.
You just have a different answer.
Right.
Yeah.
So, Marissa,
Probably those folks are the best people to address your particular questions.
Because I don't think getting him, I don't necessarily want him to like lose weight, but he doesn't need to get bigger. He's only 11.
Yeah.
He is tall.
Sure,
for
he
his
can
age,
maintain his weight
right,
and
maintain-
grow as he
taller,
grows in
that's taller,
stature.
you
He'll
know,
stretch out.
you
Yeah.
know, family history of obesity, yes,
Mhm.
I do. I recognize that, when the young lady mentioned genetics, I was like, it's probably genetics with us as well,
Mhm.
as well as his selective eating. But just even getting him to taste something,
Yeah.
just not, even if it's something, try a little piece of cake. He doesn't eat bread,
Uh-huh.
things that you would think that would make him gain weight. He doesn't eat those things, you know.
Right.
So it's just kind of like, pizza is you can motivate him with pizza and his tablet with anything, literally.
Mhm.
That's like his lifeline. But I bet he will eat apples, but other than that, that's
Uh-huh.
it,
Yeah.
So, I'm just thinking, just to get him to taste.
Taste.
When he said that when
Yeah.
the mom wanted the 3 bites of vegetables, I would be happy,
Right.
from just even tasting
Right.
them,
Right. I think in your situation, I do think the folks in the feeding program would be best suited to work with that.
Mhm.
And I'm sorry you didn't have a lot of success in the past. Yeah. Yeah. Thanks, everybody. Thank you so much. All right.